already made her the host.
So good afternoon, everyone. Welcome to this panel discussion on the topic of psychoeducation of family members in mental health. Now, this is a very important topic in mental health. And as we celebrate May, the Mental Health Awareness Month, we have organized this event. In our practice as mental health professionals, we see that the clients and patients they always feel that, and it's their experience, that family members have a big role to play in the successful outcomes for them in the mental health treatment. So we are going to look at psychoeducation for family members, and through this panel discussion, we'll talk about what it means, what it is, what is its importance, and so on. We have a very distinguished panel here with us. We are very, very fortunate to have these experts who volunteered their time to be on this panel. Dr. Harish Shetty. He's a psychiatrist with over 3 decades of experience. And apart from treating clients with psychiatric illness, he has done extensive work in the areas of mental health, especially in connection with disasters. He has worked with youth, works with educational institutions almost every week. He's doing some session. He's a governing body member for NTA appointed by Government of India, member of Indian Medical Association, Indian Psychiatric Society. He's on the advisory board of top counseling and wellness centers. He has worked in the Latur in 1992-93 for a year, Kandla after the cyclone. So he has done a lot of work in psychosocial processes and volunteer work after these natural disasters, and extensive experience in as a volunteer and a practicing psychiatrist. Welcome, sir. We have with us Dr. Rahul Sidhiye. He's a clinical psychiatrist and epidemiologist. He has worked in the field of global mental health for last 17 years in India and other low and middle income countries, with a specific focus on reducing treatment gap for mental disorders by translating evidence-based treatments in real-world settings. Based on his work to integrate mental health in primary care, he completed PhD from Maastricht University in 2018. He has addressed the UN, WHO on topics of mental health. He has been a faculty at King's College, UK, and currently is an associate professor of psychiatry and senior research scientist at Pravara Institute of Medical Sciences. He is the recipient of India Alliance, Department of Biotechnology, Government of India Wellcome Trust Intermediate Fellowship in Clinical and Public Health Research, and his work involves design and evolution of yoga-based interventions for mental disorders. Welcome, Dr. Rahul. We have with us Mona Sharma. She's a cognitive behavior therapist, a clinical psychologist, and a public mental health professional. She runs a service user organization, Manorathi Foundation in India. Before this, Mona has worked with various global and Indian organizations in the capacity of public health professional and a rehabilitation psychologist. And her areas of interest are capacity building in mental health care and mental health advocacy. Welcome, Mona. We have with us Dr. Ramila Shekhar. She had her early education at Mangalore and then went on to pursue her study at MIMHANS, Bangalore. She served as a professor and head of the department and dean PG department of Roshni Nilaya for 34 years. Currently, she's the director and practicing child, adolescent, and youth mental health professional at Manashanti Counseling Training and Research Center, Mangalore, which she initiated. She has conducted more than 1,000 programs for students, parents, teachers, members of various government and corporate sectors on family life, family relationships, child mental health and healthy personality, stress management, mental health first aid, prevention of sexual harassment, in different parts of Karnataka and South India. And she's a published author in a number of research papers in the national and international journals. And she was conferred the Best Educationist Award by the Global Society for Health and Education Growth, New Delhi in 2015. Welcome, Dr. Ramila.
Thank you.
And I am accompanied by my team members from Swasti Vishwa Institute, Meghna Deshpande, who's coordinating this event, and Aditi Joshi, who's also coordinating this event. And they will help me in also moderating this discussion, this panel discussion today. So welcome Meghna and Aditi. Again, welcome all the participants who have joined in. This is also being live streamed on YouTube. So welcome all the YouTube viewers. And we are going to explore this. The structure of this panel discussion is that I'll just start with a question and then we will get answers from our panelists. And we are going to keep it kind of in a flow, informal, and we will try to answer all the questions. And if we can't answer all the questions if your questions are not addressed in the panel discussion itself, we will go back to the questions on YouTube and answer the questions over there. So we'll try to incorporate as many questions as possible. So with that, let us start the panel discussion. And to give us a perspective on mental health and the need for this kind of psychoeducation, just the incidence in terms of, what are the numbers? I would request Dr. Rahul to share some of his, studies that he has done and what he has found in terms of incidence in mental health. So Rahul.
Well, thank you, Swati, and namaste to all of you. I hope I'm audible. Are you okay? Good. So, thank you, Swati, for first of all inviting me to this panel discussion and giving me the opportunity to kind of kickstart this discussion. As you mentioned, we would like to start this particular discussion by looking at the numbers or the need for mental health awareness and why we need to kind of why this needs to be a focus area. So before going into the numbers and statistics, which could be pretty boring, I would like to start with a story of Gautam Buddha and Kisa Gautami. I'm sure almost all of you must have heard about this story. So just in nutshell, Kisa Gautami was someone who was living as a contemporary in the city of Shravasti. And she was a wealthy woman who lost her very young son and was very, very disturbed by that whole.
This meeting is being recorded.
So was very disturbed by that particular incident. She approached Gautam Buddha and she was, of course, going through the phase of grief. And she requested Buddha to kind of help her. Buddha said that basically to revive her son, and Buddha assured her that her son can very well be revived if she is able to find a handful of mustard seeds from some family where no one has died or where no death has happened. And then she went home and home to home, family to family, and to find out that basically there's no family or there's no home where people had or family members had not experienced death of their loved one. This story basically underlines the fact that every family, every household has brushed with death, has some brush with stress and distress in life. And that is how the ubiquitousness of mental health conditions is. It affects everyone. So numbers really, they do matter, but at the end of the day, as human beings, we all have to have some brush with mental health conditions, and all of us need to work on improving mental health. And how we can do that, maybe this panel discussion can throw some light on. Now, coming back to the numbers and the actual numbers, and kind of to put things in perspective, I would, rather than going into a number of studies which many people in India and across the world have done, I would simply quote some figures from from a study which was published a couple of years ago, and this is based on the global burden of disease data. So something which is very, very standardized. So this was published in early 2020, late 2019, and what the global burden of disease India study found was that 1 in every 7 Indians had one or the other mental disorder. So with varying severity, but it says that every seventh Indian requires some or the other professional help. So as I had earlier said, that every family or every human being has some or the other mental health issue or mental health condition. But when it comes to seeking professional help, or when it comes to a particular mental disorder which requires some form of treatment, that number is around 1 in 7, which translates to a close to 20 crore people living in India. Now, 20 crore is a huge number. It is as good as population of Pakistan or a population of entire state of Uttar Pradesh. So that is the number of people in India who, at any given point of time, are suffering from a mental disorder. And out of these, close to half of them suffer from either depression or anxiety disorder. So depression and anxiety disorders are very common in Indian context. In that particular year, they found that the estimate for people with depression is around 4.5 crores. So 4.5 crores is also a huge number. It is as good as three-fourths of the United Kingdom or any Western European nation. So these are the numbers which we are dealing with at this point of time. Now, why these numbers are important, or why mental disorders are important? And I would simply like to state that in maybe in 4 sentences. So the first thing is they're extremely disabling. So a person with depression and person without depression, there's a whole lot of difference between the way they can function. There is a lot of disability associated with major depression, anxiety disorders, and other mental disorders. In fact, depression is the second, and soon it's going to be the leading cause of disability across the globe. So this is something which is extremely disabling. And if a person has a schizophrenia or other severe mental disorder, then the disability can be very, very high. Uh, Second thing is it can be very discriminatory as well. So a person with mental disorder faces a lot of discrimination. There is stigma associated with this disorders. The third thing is it could be dehumanizing. At some time, at a particular point of time, people with severe mental disorders, with schizophrenia, mania, are chained, they are locked, and they have to undergo human rights violation. And finally, this can also lead to suicides, excess death. So depression is very, very closely associated with the incidence of suicide. Now, we had last 2.5 years were all like COVID years, and we know the numbers associated with COVID. In India, close to 5 lakh people have died of COVID. But we don't know that close to 1.5 to 2 lakh people die of suicide in India every year. So in last 3 years, we have more or less had similar amount of suicides as much as COVID deaths. But we don't seem to kind of worry so much about suicides, which are again, I mean, they could be prevented. But we have a whole lot of discourse on COVID. So just these four things about disability, discrimination, dehumanization, and death, and those numbers are there for us to kind of kickstart this discussion. I won't go into the details, simply these numbers to start the discussion. And over to you, Swat.
Wow, my goodness, Rahul, that was eye-opening to say the least. And this kind of is suddenly putting the entire context itself into a very different, viewpoint, I should say, or the nature of, the seriousness of this topic itself. And what one can do as professionals, what can we do as family members, what can we do, and what can the clients or the patients themselves do, right? So with that, I'm keeping this open to the panel. What are the myths about mental health? I mean, there's so much misunderstanding about this. There's crores of people undergoing these issues, but the understanding about it is not a lot among the general public. So let me keep this open to the panel. Dr. Harish Shetty, if you would like to give some perspectives.
There are many myths about mental illness across the world. It's not only in India. But what we see generally is, one is that it should have a cause. What is the root cause? Has the root cause क्या है? इसका root cause क्या है? And sometimes there is no root, there is no cause. There is no मूलभूत कारण. मूल पढ़ना है आणि भूत पढ़ना है. So that is that root cause analysis which we generally do in engineering. Second is it is because of witchcraft. My son was never like this in the past. It just happened 6 months ago. And what is very important in our practice is to believe that people have myths. Even if somebody says we don't believe in it, believe that they have myths, because it's important to elicit myths. Because when myths leave the brain, there is space enough for science to enter. Acknowledge them. Don't dismiss them. Don't laugh at them. Don't look at them with a lot of condescending attitude. Acknowledge them, because that is the culture in which we are. And as you acknowledge the myths and you accept the myths in their perspective, the compliance for treatment improves, and that is very important for us to understand. So apart from the figures which Dr. Rahul quoted, 2019 December, all of us should know that there's a 10% increase in suicides in 2020 in India. 1 out of 3 people end their life by suicides because of family problems. So family mental health is extremely important. And 2 other significant points are that 1 out of 4 people who end their life by suicides are daily wage laborers. Globalization blinds the lives of the poor. Health and education has been completely left aside for the poor. And suicides, there is direct correlation between low education and suicides. So these are some figures. So there are million myths, and the best way to practice is, number 1, believe that people have myths, try and elicit it, acknowledge it, let them share their myths as much as they can, then their compliance increases, even little scientific facts also are accepted. And what is also very important is that when they come and when they improve after 15 days, they say, "Ami gavi जाऊन येणार, हम गांव जाके आएंगे, वो हमारा कुल देवता है." Explore that. Nothing wrong with the kul devta. Explore that, whether they are going to just pray to God and come back, or they're going to get into a lot of expensive mumbo jumbo exercise that people say, "Aapke ghar mein Shah naam ka koi hai kya? Pa naam ka koi hai kya? इन्होंने आपके ऊपर करनी किया है." They are responsible for this illness. So we need to understand that even if it's an IAS officer, a medical doctor, a laborer, myths are galore, elicited, acknowledged, and strategically dent it in their lifetimes, which helps them to accept science and improve compliance. And that, I think, is very important. Lastly, every family has a person who takes decisions. They are not the same for all issues. Some are important to take the decisions of which holiday, where would they go for holiday. Some would take the decisions of which house to buy, which soap to use, which food to use. But there is 1 person, 1 or 2 persons in every family, a grandfather, a grandmother, uncle, or a doctor in USA, who decides where to take treatment, should you take it or not, etc., etc. Identify the ally so that you can fight the myths much better.
Wow. So, Dr. Harish, this is a very interesting perspective that you have opened our eyes to, that instead of fighting the myths, you accept the myths and try to acknowledge those myths, find out those myths, acknowledge those myths, and then try to work through those myths so that there is more compliance in terms of, say, treatment or approaches, or more acceptance to science. So again, very true.
Also, Swati, if there's a paranoid patient, extremely, he'll ask you, "Do you believe in it?" I say, "Of course I believe in it. Of course, this is because of that auntie who doesn't believe in it. And but take my medicines," and gradually the compliance also improves. And also, what is important is, don't try to do everything at one go. Incremental exposure to denting myths across time is very important. Don't give a devastating picture. Schizophrenia hai, zindagi bhar dawa lena padega. No, no, no. You start your medicines. Let's look at it. Let's go one step at a time.
So, yes, Dr. Amila.
Yeah, I think because it was a very nice start that Dr. Rahul and Dr. Harish gave. So I just want to add, I think it's the same everywhere. The belief that the wrath of the god, the witchcraft, in down south we have the devil worship, the Bhuta as we call it in our down south. Lot of people have those beliefs. Now, apart from that, me working with children and adolescents, two more myths that I really come across is that bad parenting is the cause for psychological issues in children. And parents feel very, very guilty about it. I have done something that time. When he was 4 years old, I beat him. So I think that's why he's gone.
Karma.
Now, yes, absolutely. The karma effect, and even not only the karma effect, but something they have done in reality. Maybe they scolded him, they beat him, because somewhere that exaggerates so much that you not only see the child having an issue, but you also see the mother having another, issue, which also needs a lot of help. And that is where exactly I think the topic of today comes. That is psychoeducation, because that is where we need to be able to tell the family members, give information to the family members about the psychological problem, the psychiatric illness, and as Dr. Harish rightly said, the treatment options. Why I'm saying using the word treatment options is, Dr. Harish, because in Mangalore, I am from Mangalore. So one thing that I have seen is
So am I.
I used to get referrals from the faith healers. I used to get referrals from the pundits. And I have always made it a point to go back to them and tell them what I have done. I've always made it a point. I'm not, because I don't take that as non-scientific and we are supposed, but I've gone and done that saying, thank you for this referral. And I am working on these lines. Okay. And exactly as Dr. Harish said, I tell the parents, go, believe that has cured you, but don't waste money or too much of money on that. And the result of that for me today is that the referrals from these, priests and the faith healers has increased. It's not, I'm not talking of the number that has come to me, but I'm talking about that we can work together. Because I think in India, you need to go to the grassroots level. That's something that is very important. So that's exactly for me what is psychoeducation. It's a process where information is given to them so that they understand it, they know the treatment options, and ultimately what is important, they are able to cope with the illness, because we want them to cope with the illness. Like exactly, I think the 4Ds, I think Dr. Rahul, that 4Ds were really fantastic. Yours, the disabling, discrimination, now those 4Ds can be dealt only with psychoeducation. I think that's
Correct.
the very important aspect of what you're speaking about today.
Absolutely. Dr. Amila, again, a wonderful perspective. And this also brings into focus the importance of culture, what Dr. Harish and yourself, what you have told, that our treatment options are also embedded in our belief systems and our culture. And we cannot just completely alienate ourselves as professionals or as somebody who is treating or providing treatment from the culture in which we are operating.
Absolutely.
Because in psychology, if you look at it, we have a biopsychosocial model.
Absolutely.
And we cannot ignore the social part, we cannot ignore the psycho part, we cannot ignore the bio part. So everything together, even as professionals, I think a lot of research like what Rahul and Mona do, and Dr. Harish and Dr. Amila as practitioners, we have to probably work hand in hand to look at how these three factors are operating in India. We have a lot of Western models, but the ground research, really good research in this kind of a integrated approach, maybe that's something that we have to as professionals, as practitioners, we can think about. I would like to ask Mona for her perspectives on this topic.
Thank you, Swati. I would like to add, I mean, I agree with what Rahul, Dr. Shetty, and Ramila talked about. I can add my personal perspective. Apart from being a mental health professional, I'm also a person who's close family members in the last 42, 43 years. I have always had one or two close family members with major psychiatric illness. I was just thinking just now when all of you were talking, especially when Dr. Shetty were talking about, the myths, not the myths, but the beliefs that family members have. I was thinking about the emotions that we as a family went through. Every time we knew there is another family member who is now diagnosed with illness, starting from my mother to now my father-in-law. So, first emotion even now is that of not again, probably is misdiagnosed. I'm a mental health professional. I run a service user organization, but even now, first my emotion when I know somebody close in my family has illness or is relapsing, first thought is that I hope it's not a severe mental illness. Then there is guilt. Why did I not, why did I not know it on time? Why did I not, why was I not aware when the symptoms were developing? There is anger. There is anger towards other family members.
Mhm.
There's fear. There's sadness. There's a feeling of loss. So I can understand, but I remember when I was young and when I did not know these feelings, when my father did not know how to process, my grandparents did not know how to process this feeling. What helped was that, having a belief that probably it's karma. Dealing with these emotions is difficult. So we need some explanation. Mental health, we all know, is still not, no matter how much we say awareness is there, it's better than it was, say, 20 years ago. But still, mental health is still not a part of our usual day-to-day discourse. So yeah, we all needed a belief. So I think this is where the myths came from. Even now, probably as a person, as a professional, I understand where it is coming from. But as a family member, even now, I go through it. I end up, blaming somebody. I just a few weeks ago when my mother had a relapse, I went and I blamed my father that why did you not see the relapse? So all these beliefs, I'm just what I'm trying to say. There's another, there's more to it, to these beliefs. And I agree with Dr. Shetty there that challenging these beliefs, because these are the support mechanism for families. You can't challenge them. You challenge them, you challenge their support systems. Unless you have helped them deal with all these emotions of sadness, guilt, anger, fear, don't challenge that belief. Even if you think it's a myth, let it be. Challenge it once you have helped them to deal with those other emotions.
Very good. Thank you, Mona. That was an amazing perspective. Also, you shared your experience, and that is something that we all can relate to, because when you get the diagnosis, what the family members go through, what the client goes through. And I think Rahul has raised his hand. Rahul, you want to add on to this?
Yes, very quickly, just following on the points made by all the speakers. So first of all, as Mona had very openly shared about the process through which she and everyone in the family went through, I think it's important for mental health professionals in this particular group to also realize the importance of experiencing some of these things. This is not some theoretical discussion happening somewhere. Psychology, psychiatry is very intimately connected. And unless you go through some of those things, I mean, I also experienced loss of my mother, and that is what led me to kind of further exploration into the grief and sadness and guilt feeling and so on and so forth. We should not restrict psychiatry, psychology, or mental health to purely biological explanations or some kind of a science which happens outside as a some kind of an objective reality. So thanks, Mona, for bringing that personal perspective into the discussion. Two things which Dr. Shetty said, and I would love to underline them again. So one is about the fact that myths are not just in India. somehow India, I mean, being in India and speaking to Indians, we tend to think that this is some kind of an Indian phenomenon, some third world country, less educated people have this sort of myths only in rural areas or people from rural background. No, that's not the case. All of us have experienced myth making during last 2 years as part of the COVID situation. I mean, across the world, across the scientific communities, everywhere, what we were doing as part of the COVID management, I mean, it was based on, let us say, some good belief systems. But it was not like pure science or something. Let's be very open about it. So not just mental health, but there are limitations to science. There are limitations to objective evaluations, and one needs to also understand one other point which Dr. Shetty made, was that there is no mulabhuta karan. Many times it is not possible to find a reason or cause for cancers, for other non-communicable diseases, for deaths. And one of my professors in KEM hospital, he used to say that disease is the function of body and death is the function of time. So that kind of has remained with me. So it is futile trying to understand the causality and what we need to focus on, what we can do here and now. And just one last point about, because this was all very interesting discussion about myths and things like that. It reminds me the first time when I met Dr. Shetty. Of course, Dr. Shetty may not remember this, but this was in 2004 when he had organized this Western Psychiatry Society conference in Mumbai. And that was the time when I had presented my first paper. I was just a first year resident in psychiatry. And this was about traditional healing practices in psychiatry patients. And one of someone in the audience, I cannot name that person, but he was very angry with the fact that how can we talk about not challenging some of these beliefs, and not and how can we be partners with traditional healers? I mean, they do some absolutely wrong things, and they violate human rights and things like that. And I don't know from where that whole courage came to me. And I was just first year resident. I said, forget about traditional healers. Just look at our colleagues in here and around, and how much of malpractice we do as sort of psychiatrists or psychologists or medical professionals. I'm not saying that every psychiatrist or every medical professional is corrupt, but corruption happens, and that's human nature. I mean, let's not go after each and every person thinking that every traditional healer is a criminal, and then every medical professional is an avatar of Vishnu. That's not the case. So we have to be humane. And at that time around, I had read about Albert Schweitzer's work in Belgium. And this person, again, in interest of time, I won't go into the details, but he in his lot of autobiographical works and books, he has mentioned about how he learned a lot from traditional healers in Belgium. That is the kind of humility, and that is the kind of respect we should have for knowledge and things around us. Let's not I mean, the good part is that none of the speakers over here, we are all very open-minded, but that openness and that kind of a liberal thinking process has to be brought into our everyday life. So thank you so much, Ramila ji and Harish ji and Mona, for bringing all these points. And good to have this kind of lively discussion where we can talk about things which exist in this particular society and how we move forward. Thank you.
Amazing.
Absolutely. I think I just want to add a couple of things, if Swati allows me.
Go ahead.
Yeah. So as Ramila ji said about adolescence, it's so important to work with parents. And there are two words which are important here. We'll have to manage the shame, manage the blame. Two keywords which are so important. Professor Vig, who led mental health across Southeast Asia, has seen people in mosques in Egypt conducting mental health camps. So Professor Vig used to tell me that by subject and as Ramila said, we have a lot of Maulanas, fathers, nurses, sisters, and from all folks. And in my clinic, they come in with their uniforms and sit with all other patients in the last 10 to 15 years. There's openness. But there are three other things with respect to mental illness. When a patient's relative speaks about schizophrenia kya hai, even after 15 years of treatment, Remember, don't get angry. The agony inside stops him from accepting psychoeducation. Agony is inversely proportional to education. Unless you manage that agony, education does not seep inside. And that is something very important. The second important thing is every patient wants Dawa Mukta Bharat. I will not use the other Mukta Bharat. Dawa se Mukti. When will my medicine stop? And with a lot of metaphors, this can be actually negotiated. I use the metaphor of the spectacle. When will the number of the specs go down? Or when will you throw off your spectacles? And so many other metaphors. But this is something, if you do not negotiate, there is poor compliance, there is stoppage of medications, and there is a lot of relapse. And this is also something very important. So again, who are our allies? Who are our enemies? The pharmaceutical selling shop. Most of the time they say, "Itna bhari dawa kisne diya hai? ये तो नींद की दवा है." खलास, he stops medication. Number 2 is इससे kidney liver खत्म हो जाएगा. Extremely common. Number 4 is ये psychologist के पास क्यों जाते हो? आप ही उनको दे दो ना अच्छा counseling. आप पिता हो, you are the father, you are the mother. You can give better counseling than Rabila and Mona put together. So believing that these are there, even IAS officer, IPS officers, senior, they say it in a very sophisticated manner. In the Atharvaveda, it is seen that there are certain parapsychological forces that can cause mental illness. Hit them gently, but sometimes you have to hit them straight. And once in a while, Ramila, when a child wants to end his life, a school-going kid, and the parents, in spite of everything, when they say, "Hum kuch nahi karenge," ye sab bakwas, I tell them, do you love your kid or you don't love your kid? Do you want your kid to live on the earth or live on the wall? And sometimes they might get angry with me, but they go to somebody else and take treatment. So we need to not to row the boat in improving compliance. We need to rock the boat also in improving compliance. And that I think is very important. Work with all faith healers. And there's no choice. You get only 5% of your patients. 95% of patients are with the faith healers. And please, when you start your practice, don't only go and look at general practitioners and hospitals. Go and check who are the faith healers of different communities and go and meet them. And then they know where they should treat, and then they also know where you should go. So, and again, a last sentence, all mental health professionals should start support group, at least one support group. If you like to start a support group of teenagers, please start it. If you like to start a support group of families with major mental illness, please start it. Support groups change the dynamics of healing. What they tell you in your clinic is not what they will tell you in a support group. And in my experience of a support group for patients suffering from schizophrenia, across time, it has stopped because of this COVID. 4 things. Number 1, compliance is better. Number 2, interpersonal relationships inside the house is better. Number 3, occupational functioning is better. Number 4, suicides are very, very less. And number 5, quality of life is better. So I think India, we need to work with support groups. There are only 6,000 psychiatrists and some 25,000 other mental professionals.
Wow. So Dr. Harish, that was again a great perspective. I mean, apart from psychoeducation for family members, I think this panel is also doing psychoeducation for mental health professionals. We are also talking about community interventions. I mean, just the expanse and the extent of this topic, where all it is applicable, it's just coming out through your experiences, our panelists' experiences, and just sharing their views and their experiences through all these years of their practice. So, it's really an eye-opener for all of us who are attending this discussion today. Now, moving on to a little more concrete kind of, what exactly family members need to do, how to communicate with a member. So once they get the diagnosis, you're, working with those myths, or you're rocking the boat or rowing the boat. Those approaches have to be different for different families and different people. One of the important thing is, whenever somebody is suffering from a mental illness or an issue, the family members really struggle. How should I communicate with this person? What should I tell? So can I ask one of the panelists, Mona, maybe you can share your perspective on this? Like how should a family member, because this is a question we as practitioners get, how should I talk to my wife? How should I talk to my child? How should? So can Mona start off this bit?
Thank you, Swati. So we work currently. I'm working with many parents whose children or family members were diagnosed recently, and I know some of them have also joined the group today. So I always tell them, one, now the whole definition of families is also changing. See, a few years ago when I said families, it mostly consisted of parents. Now I see siblings, children, grandchildren, spouses. They are also coming forward, and these are people who are younger than, say, parents. They are more receptive to understanding. They understand mental health better. They are little this is what my experience has been, that siblings or children or a spouse, they are more open to understanding that about mental illness, importance of medicines and all. How do you tell the person? I always say that don't start with telling them the diagnosis. Don't say you have schizophrenia or bipolar disorder. Talk about what problems they are experiencing. So what is happening? I think say like young person who's just been diagnosed, probably it starts with I'm getting bullied in school or college. I don't want to go out. I want to complete my degree, but I don't want to go to college every day because uh, I'm not able to concentrate. I think my friends are talking against me. So this is where we start from. Okay, fine. This is what you are experiencing. This is a problem area. Let us see what we can do about it. So usually this is from where we start, and we say, do you want to go and talk to this psychiatrist who probably would be able to tell you what is happening? Is somebody really talking about you, or you think somebody is talking about you, and what we can do about it? They take time, a little time to form trust, but usually the medicine start. Once the medicine start, we negotiate. We negotiate mostly. This the diagnosis happened when they are adolescent or early adulthood. So at this stage, we do reasoning. We train the family members how to talk to the person who has illness, how to reason it. Why medicines are needed. We also try to balance by saying, okay, let's take the medicine for a few weeks, and you come back and tell us how you feel about it. And mostly I've seen there are changes, there are positive changes, and the person start then they agree. We don't, like the Dr. Shetty said, usually when I don't say you're going to take it all your life, yes, then let's start it, take for 2 weeks and come back to me, tell me how you will feel about it. So so each individual case is different, but then these are some of the principles that I keep in mind, that don't start with telling you have schizophrenia, now you have to take medicine for all your life. Just start with the areas where they are facing and they need help. If there's a difficulty when the illness starts, there's so much of confusion in the mind of the person, what's happening, what's going wrong, so everything seems to be going wrong, the world is coming down, they need help. Even if they're angry with the family members, they're angry with the psychiatrist, they still need help. We just have to find that window, and usually you find a window. I tell the family members, find that window where you can connect with them. Initially it's very difficult to connect with the person, but if they shut themselves in the room, they are not eating. This is what happened with my father. He stopped eating. Father, he stopped eating, he would not eat at home. So you have to find that small window, where they can connect with you, where they agree. There's one family member or friend, whoever it is, who they would listen to, who they would agree to go with to meet a psychiatrist or a psychologist. So find that window that would help you to hold their hand and agree to seek help.
Take help. Great, Mona. Good perspective. And I think this finding the window is something very critical. We have had this in our practice where we had to
hashtag
members. Yes, absolutely. I think Dr. Ramila wanted to say something.
Yes, yeah. I fully agree with Mona, because I think one thing that if we are careful not to use the jargons, because I think that actually touches the family. So if you ask me, how do I do it? Most of the time, I think I use very simple language. The language that they are able to understand. It should not be like, like simple example, it's a dysfunctional family. They will not understand the meaning of dysfunction. They think my family is gone, and the whole thing starts from there. So I look at it in a very simple language. I first, most of the time what I do is, even when they come with a adult patient or with a young child, I start asking them the positives of that child and the positives of themselves. Like if it's a mother, I say, tell me all the nice things that you did about as a mother. And that woman feels very nice, because all this time she has been blaming herself. Others have been blaming, you didn't do that. If you had done it, it would have been better. And you shouldn't have allowed him. That's why he's gone to this age, this stage. So now when you ask her to talk about something that is, positive, she starts talking about it. And you can actually see the body language in both the person, if they are together, in both the person and the family member, changing as they're talking about their positives. And from there, then I start talking to them and giving them, saying that, okay, now you see, this is all the positives. Now, what are the things that you need to, modify? What is it that you want in this child to modify? Like simple example, I'll give you. We just had a 10th and PUC and +2 examination. We had a lot of parents coming to us with this, habit of children not wanting to leave the technology. If you want to call it as a jargon, you call it as internet addiction. But I would just say they are, they want to be with the gadget. So then I slowly ask the parents, like, tell me what you want in the child. And the parent will say, no, I don't mind him seeing the mobile, but it shouldn't be that much. So then I realize it's totally what he has asked, what the mother has asked here or the father has asked here in front of me is totally different from what she or he has asked at home. At home, she would say, I will not allow you to see the gadget. See, that makes so much of a difference. And this boy also starts feeling, okay, she's saying that it's okay. So then we start having the conversation there. So from there, from information, then slowly we move on to giving them some coping skills. How do they cope up with the situation? It could be hallucination. It could be, as Dr. Shetty said, the delusions. It could be then, that he's not doing anything. He's just, an IT person who was working all this time, suddenly after this episode is not wanting to go to work. And parents are not able to understand how my 29-year-old fellow can sleep like this. So then we help them with slow skill development, coping with skills. And when they are doing the coping with skills, I think they need a lot of that back support. It's only with support that they are able to do. The support given to the person and the support given to the family. So I think this is, it has to be a slow. I think one thing, I don't know, I think all of us are talking about what as mental health professionals. I think one quality a mental health professional should have is patience. I think that's something that's very important, because as Dr. Shetty and others said, you can tell them everything in the first session, and the second session they're coming and sitting in front of you and asking you the same question. Why your mom?
After
Why
15
this?
years.
Why?
After 15
Absolutely,
years.
sir. Yes, sir. I know. Yes. So, I think we shouldn't lose our patience. We should understand that emotion that I think Mona spoke about so well. If you are able to understand their emotions, I think we can guide them, we can go along with them. I think that is important. Go along with them and help them. And she spoke about the window. I always keep telling my students and my colleagues, give that hand. They just need that hand to come out, and if you are able to extend that hand, they can come out of that, problems.
Wow.
Hashtag give the hand. Give the hand.
Yes. Dr. Harish, you're suggesting all the hashtags. Meghna, please make a note of all those hashtags. He's pointing them out, and these are extremely important hashtags. I mean, I think we should all remember these. What was that? The window, give a hand. So what Dr. Ramila really brought out is it's not just the client or the patient who is needing this kind of help, but also the family members who need to be educated, who need support, who need to also know how to cope with whatever is happening in the family. So because they are also anxious, they also don't know what to do. They may be confused, they may be afraid, they may be guilty. So all these kind of emotions may be present in the family members, and they may be confused as to what can I do about it. And some of them may also feel helpless. So I think to
Absolutely.
make them feel empowered that they are a big role, they have a big role to play in making this person feel better or towards better well-being, the psychological well-being of the family member. I think that is a very important aspect of psychoeducation. Another question that, yes, Rahul, you wanted to say something?
Yes, again, very, very quickly. Now, what has happened with me as a professional, I have not practiced as a clinician 24/7 so I have been a family member come psychiatrist. So I'm a psychiatrist to my family members most of the times, and very few patients who I tend to consult become my family members. So what I've realized over a period of time is that beyond my prescriptions or beyond any technical psychoeducation, all that they care is the fact that I'm available to them whenever they wish to meet me or whenever they wish to talk to me. So my availability without and over a period of time, I realized that I don't have to even. I just have to be there and just do some kind of a very non-judgmental listening. All that is what people really want, and so it becomes really easy. I mean, during initial years of my training, it was like, oh, I need to learn this, I need to learn that, and no one taught me that all that you need to learn. Basically, you need to learn active listening. Well, they do teach that, but active listening and being available and looking for that window are some of those things which not just mental health professionals, but even family members can do. So a family, I mean, you are a close, and it is very difficult. I mean, if you have a family member who's suffering, you cannot be in that state of mind where you can be available and patient and so on and so forth. But try to do that. I mean, if you try, many a times the response from the person who is suffering can be completely different. And also bear in the mind that no one would come and tell you that just because you were available and you listened to me, I felt better. No one will tell you that. Many a times people don't say all these things. These are all very non-verbal, and one needs to be again patient with the fact that the feedback may not be instant. They may tell you 10 years later, 20 years later, after a very, very long time. But that is important. So being available is one thing. Ramilaji, one thing also I've noticed, again, this is not, I won't generalize this. And I am of the view that things have to be extremely simplified and we have to not worry about the technical jargons and details. But with some people, I've realized that jargon needs to be introduced as some kind of a instrument, as in like a Caesar. You need that kind of a scalpel for surgery. Similarly, some people need jargon. They need diagnosis. So one of my patients was so happy when I told him that this is your diagnosis, and he was like, "Oh, now I know that this is what I'm suffering from." So I said I kept away that diagnosis from you just because it doesn't mean. I mean, that's just some collection of words. But no, for him that was very important. I said fine. So one lesson which I've learned over a period of time dealing with my students, with my patients, and with my other colleagues is that sometimes it is important to jargonize. So because some people love jargon, and there are multiple other such examples. So those are the two things which I thought that as a family member also one can do. You don't have to be an expert, a professional to give a lending ear or to have active listening skills. You can do that as a family member to people around you. As even as part of the community, you could be available to people around you who are in your workplace, who are in your immediate neighborhood. All those things could be done, and unless we actively engage into this, we simply cannot rely on the number of psychiatrists and psychologists and experts. We all have to make this as our business as individuals, as human beings, and not so much as professionals.
Yeah,
I
just
think,
one thing. I'll just come in here. Yeah, I'll just to tell what Dr. Rahul said. I think it's important because another thing that we also face here is now many family members come with the diagnosis to us. Just yesterday this happened when I went to a school for a program, and there I had a teacher said, I have a child who is ADHD. I said, how do you know that? No, ma'am, I just saw, all that is there in Google. So there, actually, I left the program and I gave one huge, explanation of what it is and what happens when they label this child as an ADHD. What is our reactions? That's so. I think what I fully agree with you, doctor, because sometimes they do need it because they come itself with that. And for me, what becomes easy is I have my psychiatrist with me. So many a times these things are dealt by him, and I deal with the other non-psychiatric aspects. Together we do it. So that becomes much more easier for us.
I'll quickly address this in 1.5 minutes, if you allow me. Many patients come to us after 10-15 years saying that उनको अभी तक किसी ने बताया नहीं उनको क्या हुआ है. They say chemical का problem है, so they need to be told and they're prepared to accept it. Number one. Number two, there's a lot of discontent at Indians suddenly saying मुझे bipolar है, तुमको ADHD है, तुमको मुझे depression है, I think I've got depression. I think it's a great thing. When the awareness improves, a lot of people will use that jargons continuously, and that is the buzz effect of increased awareness. And I agree completely with Ramila that when a teacher says, I congratulate her, I think she has made an attempt to look at this and
look at the Google.
Clarify.
So there are
what is
there are two perspectives here. One perspective, Dr. Harish, you are saying that it's okay, at least it's creating a buzz. Wow. It's creating that kind of an awareness. And Dr. Ramila is also bringing the other side of the coin, is that they may be completely misdiagnosing. Or
but at the same time, awareness is there, and if you're there,
awareness,
Now, for example, if a mother comes and says, "ये हमारे ADHD है, LD है, और opposition disorder," then I say, "आपका बच्चे का नाम क्या है?"
That's true.
His name. So you need to balance. But what is very important for all of us is that you ask this question: what are the things families should do? So families come and ask us, you tell us how we should behave with our patient, and that requires very clear understanding. Family needs clarity because mental health is not philosophy; it is science. It may not be quantum physics, but it's science. So we wrote a booklet for the Week magazine on depression years ago, and there's one chapter I wrote on what should the family do with the person who's depressed, and give very clear guidelines. Keep the medicines away from him, no pravachan at all, be with him. If mind is fractured, don't say mujhko dekho, look at syndrome. मैं 70 years से कर रहा हूँ, योगा कर रहा हूँ, मुझे देखो, मैंने जिंदगी सब कुछ किया है. Keep away from all that bullshit. So we need patya, because Indian patients need patya. It's a medical model. You have to give patya also apart from exploration, and that is something which is very important. Apart from that, mental professionals are not gods. They get tired. So what is your philosophy of practice? Are you a patient-based doctor or psychologist? Are you a people-based doctor or psychologist? Which means at least once a month, do a community activity with people. And you'll find you getting refreshed. But apart from that, you learn a lot of insights which is happening in the community, which is very important for us to understand in a clinic. You sit in your clinics all the while will keep you blind from the community. And that is something which is very important. Next is, psychoeducation is not you telling. See, it's a difference between a surgeon and a psychologist or a psychiatrist. Surgeon, even if arrogant, there are arrogant cardiac surgeons in Bombay, but they're very good with the fingers. So you don't look at the arrogance and you go under the table with a scalpel. But in mental health, there's a rapport. You might be the best in the country and somebody would say, I can't gel with him. And then psychoeducation, not only your job, you need to have a psychiatrist, a psychologist, couple of psychiatrists as team inside your clinic or in your practice. Around 6 people as your friends. I printed the names of psychiatrists in my prescription. If you're not happy with me, or if you me, these are the people whom you can go to, and I'm going to increase the numbers. So giving a choice. because sometimes your psychoeducation may not work, somebody else's might work, even if you are very experienced. So I think that is important, because as many forms of gods, it's as many forms of minds, different minds, different gods. So different minds may need different people, different personalities among mental health. That is something we need to really look at. You don't have to take everything on your shoulders. Nahi janta, ye patient ko apne sath nahi jamta hai.
Very true. I think
Kho ka kho, then have your team can assess the patient. So there is nothing like second opinion always. There's always a shared opinion.
I mean, again, a lot of perspectives on this topic itself, because psychoeducation is a very broad topic with so many dimensions to it. So, and I would like to again go back to Rahul. Yeah.
Cultural literacy is very important. You should know all the gods in your area. What people should know, Ma'am Ramila, Kola, Naga, Kuldevta, everything. And you need to have some information, some knowledge of all religions also. That is so important.
Because again, we come back to the cultural aspects, the biopsychosocial model that we keep talking about. And as professionals, we can help these families when we are holistic in our approaches also. One of the things, coming back to, communicating with the family members, generally what I do is I try to tell the family members and the clients this active listening is very important as a skill for family members also, where, for example, I tell them, try to understand the intent of this communication. Why is mom saying it? Why is dad saying it? And for the family members, I tell them, look at it from the point of view of this person who is having depression. For you, you are not wearing those dark glasses. For you, everything is clear. But somebody going through depression, they are wearing dark glasses. You can imagine if constantly you are wearing dark glasses, something that is clear, that person is not seeing it like this. So understanding the perspective of a person who is going through, say, for example, anxiety or depression, and perspective of a parent or a spouse or a sibling or whoever that other person is very, very critical. And I think this active listening skills, where you are understanding the meaning of what is being communicated between people, I think is a very critical part of educating members as well as clients. Now, coming to one or two very specific questions. One of the things is for serious mental illness, some of the family members, they will ask about rehabilitation. And I'm bringing this because it was a very specific question that was asked. Generally people with severe mental illness, they will ask about, what can I do? How is this going to be lifelong? Do they need rehabilitation? Can I send them away somewhere? So what do you tell these family members? How do you educate them about rehabilitation? So, and one more thing about not just the psychiatrist and the psychologists, I think our country also lacks those mental health social workers, which is a very, very important category of professionals who work with family members of mentally ill patients, so that the psychoeducation really happens in a more formal manner. So people who are currently, for example, with a couple of my clients, I'm only doing this kind of work, educating the family members. But we need psychiatric social workers in a large number, especially if crores of people are having mental health issues. We need these people in, I don't know, 100,000s to approach, and at the village level, at the town level, at the city level, at the community level, we need these social workers who are, who are trained in this kind of communication. So coming to this rehabilitation part of it, so we focused on the treatment part of it, how to convince them slowly, how to make sure that they are in treatment. But what happens with the rehab part of it? Like what would your suggestion be for the family members? Anyone, Mona, you would like to go for it, or?
Yes, Swati. So, you're right. We do lack. So there are some rehabilitation models in India. There are some private players in this area. And then I know in every state, there are some family groups who have come together to form. So these are probably not published models. These are the models which were thought of based on the needs, where families have come together, formed a trust, or taken a house, employed a psychologist to meet members, their family members who are going to stay in that house regularly, or they have started experimenting. I know a couple of families who have already started experimenting that, if the family member who is ill can stay independently after they are gone. So they already started, say, getting them to stay alone for a few days with, of course, support of psychologists and all, or a psychiatrist or a social worker, or caseworker. That is happening. So for instance, I know there's this organization called Samban Foundation in Gurgaon, who is started supporting families who are interested in looking at this model. Then say Schizophrenia Awareness Association in Pune. They are private, of course, people may know about these private homes. Then there are also some again, our mental health, we should also, I also do mental health advocacy. So our Mental Health Care Act, there is a clear provision that there has to be a rehabilitation center, long-term care homes. Let's not call it rehabilitation center, I call them long-term care homes. In Delhi, for instance, there is land that has been allotted by government for more than 30 years to build such a home. It's not been built. We need to go as families or as service users. We need to come together. You are not going to get it on platter. Professionals have done it. But when professionals do it, there's always, that thing, probably they're doing it for their gain or not. So I don't want to, it comes, even if it's that thought might come from, program officers or policymakers, and also let families come together with the support of professionals. Let professionals, families both come together and advocate for such long-term care homes for people living with mental health conditions. And that's needed. That's needed in every state. I don't think somebody in Delhi should go to Bangalore. Why? Why should they go to Bangalore? Because only Bangalore has good facilities. But that's not fair to the person who's lived all their life, saying, another city. So let us advocate for it. And I know many groups, for example, I don't know if there's this group called Face Me. This is an alliance of families. It's an umbrella organization with many groups under it, family groups under it. So I know they have started advocating for long-term stay homes, or what after me concerns and they're engaging with both Ministry of Family Welfare and as well as disability. Both they are trying. So they're try to engage with policymakers to get answers to these questions.
Wow. So I think, Mona, you have given us a lot of insight in this very brief, couple of minutes about a lot of advocacy groups and what these advocacy groups can do, and the potential that people can make use of, the potential that is existing for this kind of services for long-term or long-term care, or whatever those words that you used. I mean, there was something that you were saying that certain words are not used or should not be used, like
For example, caretakers. I don't use the term caretaker because I find it stressful. The moment I say I'm a caretaker, I'm not a caretaker. I'm a family member. And
family member. Exactly. Exactly.
I care for my family. That is what something I understand when I started working with families. I know this family where this woman, she left her job or career to look after her, to be with her father, then her mother. And I said, you have done, about her sacrifice. And she said, what the big deal? They are my parents. We are family. Who else would do? So that thought, when I adopted that thought, I realized that stress of, the whole, when I said I'm a caretaker, I have so many people, wherever I go, there's somebody with illness. I'm sorry, every stage of my life. But the moment I said I'm a family member, and as a family member, I care.
You care. Exactly.
Somebody's caring for me, or my friend. Somebody's caring for me.
So
perspective of family member. Then rehabilitation, I don't try to not use the term rehabilitation, though I know what it means. Is not, I'm not talking about, we are just using the term just because it changes the way you are looking at that role for you.
Right. It's very phenomenological in that sense, when you use language in a
Just,
certain
for
way,
me, it helps me.
yeah, meaning making of any language or word. Now we have, we have talked about these supportive family members, but there are also certain rights of mentally ill patients.
No, one sec, Swati, one sec.
Go ahead.
Rehab is all about, first, non-polarized caring. Like, for example, Indian families, one son is mentally ill, the other son is excluded from the entire process. उसके ऊपर कुछ असर नहीं होना चाहिए, उसको अमेरिका बिल्कुल जाना चाहिए, कोणाला काय किसी को बोलने का नहीं, उसको हम सब उसको करेंगे, and then they die, and when the brother comes, he doesn't know anything about his brother. So rehab starts in the family. I tell all my patients, please share about your son's illness, your daughter's illness, or your sister's illness to your extended family. You do not know from where the care can come. So globalization has shrunk families. Globalization does not provide caregivers inside the family. I still use the word caregiver because it's an international nomenclature, and it has the same empathy as much as a family member. So that is one. Number two is there's a Supreme Court case which is on as of now, filed by my friend, and based on the Act of Disability, and in Maharashtra, many of the patients who are mentally ill, like for example, we are not supposed to say schizophrenic patients suffering from schizophrenia. You can't say the patient committed suicide, patient died because of the act of suicide. So in this petition, the Maharashtra government has said that they have patients to beggar homes, and they're going to start halfway homes in Maharashtra as rehabilitation. And the Supreme Court really was so upset, and they said they asked them a lot of questions. It's an ongoing case. Three issues about rehab. I think I'm very happy with Mona about the umbrella organization, but there are two other issues. Number one, right when the person is ill, we are going and talking to families in schools. I'm in a school every month. I tell the children very clearly, you have to take care of your siblings and your parents as they grow old. Now, unconditional love is all good. It's conditional love. Your parents need to care for you. You need to care for them. Number two, I tell all family members in schools, the kids are young. You cannot say, you all go and study abroad. I mean, you might object to all this. You have to tell them that probably if somebody has got ADHD and severe illness, the second sibling has to be part of the caring. You can't take everything on your shoulders. So rehab starts at home. Number three, a lot of patients who can live with families are rotting in mental hospitals thanks to the mechanical reunion of patients with their families. I have filed a PIL against it in the Maharashtra High Court. The PIL says that we need to examine every patient in all four mental hospitals, whether they could have actually been reunited. The PI was inspired by a man who attempted to take divorce from a woman, from his wife, who was in Thana mental hospital. And the judge in the family court was so alert. She called for the woman and found that the woman had recovered and she could live in a family. But when they sent to the family, the husband sent him back. Through counseling, this woman has been reunited. So we need to look at families also, to accept patients who are so. I agree with Mona that families should come together and get involved in advocacy. But I would say psychiatrists and psychologists should join hands with family and in advocacy, because families alone, I mean, major mental illness, there's a lot of burden. Let us accept it as the truth. Globalization, small families, कोई किसी को time नहीं है. Globalization has caused disconnection, which is worse than HIV. And so we need a lot of advocacy from psychiatrists, psychologists, along with the families to see three things after me. Number two, how can a person safely live with a family? And how can he or she have other support system along with? And number three, destigmatizing and seeing that others accept. So Dr. Avinash Joshi, from as you know about it, you don't, Swati, you made a adverse remark on that intervention. But what he's trying disabled mental ill and other disabilities can they marry? And that is one intervention. So then we need a million interventions for rehab centers, and after me is important. That will not happen in a country which is aiming at $1 trillion economy with IITs, IIMs, and AIMS. We need hundreds of institutions with MSWs, psychologists.
Yeah.
I mean, that is so important. I agree with Mona completely, but rehab starts from home.
No,
Yeah.
Dr. Shruti, I would like to correct that. I did not say family advocacy means only families. I agree we need support with mental health professionals, psychiatrists, psychologists, social workers. And, that is needed. What I was trying to say is that, few years ago, advocacy was only led by professionals. But now I think families also need to say co-lead or lead this movement.
Knock the high courts in every state. Knock
Yeah.
the high courts in every state.
In every state, because it's their life in the end. It's
Absolutely.
the cause for them. And
it's also, Mona, what you say is right, because advocacy has to start from family members, because they know what that experience is like.
Exactly.
And that they would know what would work, what would not work. So I think it's very important to know the role of the family members in advocacy, in making sure that treatment and options and all these things are available for this particular patient or, family member. Ramila has wanted to say something. Yeah, Ramila?
Yes, no, because you were talking about rehab, and one comment that has already come is that we don't have PSWs. I don't think that's true, because I worked for 34 years in a social work college, being a PSW from NIMANS itself. I know that there are so many colleges with MSWs, but there are so many institutes which are also bringing out PSWs. But what is happening is, see, in Bangalore, when I was studying at NIMANS, I had no issues at all of helping the family, the person to go back to the community. And for me, rehab is not a structured, well-organized institution. For me, rehab is helping the person to come back to his own society and cultural background. And for that, once I started working in Mangalore, I realized that I am not looking for a huge institution, but I'm looking for the community to take back the person. And that is something that I am working now with, the family members and the community. And I think I would like to just state an example here, what Dr. Shetty said. We had this one person who had schizophrenia, and both the parents were working. There was nobody, and the alternative was they wanted to send the boy somewhere else for exactly as we call a rehab center. And then I started working with the family and said, is there anybody else who can help you out like this now? So is there somebody else? And it's only when we started having a family meeting, the mother's sister volunteered, saying that if the parents don't mind, I don't mind this boy coming and staying from morning to evening. He can go back home. And see, that whole thing, that commuting from his home to the auntie's house, meeting the other cousins, and on the way talking, all that brought about so much of an improvement. And that was I'm talking about some 15 years back, but that gave me a big lesson to learn, saying that it is not the institution with a lot of technology or with lot of facility, but it can be a small house with absolutely no facility, but there are people who are, as all of us said, available, makes it a much better place to go back.
That's very nice, Ramila. It's excellent example. I mean, I had one client with whom I was working very recently. I'm working with her. So in her house, a very similar situation, and we did find a locally embedded person who is willing to take care of the psychiatric patient. So she didn't have to go anywhere. She's finding that support right there in her home, just through the community. So I think these are some of the options that, family members can look for rehabilitation. Rahul, you want to say, you want to add something?
Yes. So when we talk about community interventions and what can community do, I think first of all, we need to kind of bring back this whole idea of collectivism and reignite this whole idea of being a sense of community. couple of decades ago, there were studies comparing outcomes of schizophrenia in the high income countries versus those in India, Nigeria, and other low income countries, and they found that in low income countries the outcomes are better because there are people who actually tend to take care of people. I mean, I live in a village, and I find there that we have two homeless mentally ill, completely taken care of by, at least their food is taken care of by the people in my village. Although I mean, there are discriminatory attitudes, but the person is not left off. I mean, again, this is not an ideal situation. All that what I'm trying to say is, as Dr. Shetty pointed out, where the help will come from, we don't know. And that's the reason why one also needs to kind of throw this into the extended family, that this is the situation. And Swati, you are also you yourself have gone through this particular situation where you have a brother-in-law with not so severe but still some kind of a mental disability, and where you definitely had a plan of what after. I mean, his mother used to take care of him, and then what after him, and both of you have done a great job, and probably the extended family is also doing it. So you will never know where the help will come from. And we all, and Indian communities, I mean, traditionally we are a collective community. We have to rekindle that idea of collectivism. And just for the mental professionals or for others who are interested in this topic, we need to also bring this whole discourse on the fact that we as individuals exist because of the community around us, and that is enshrined in the idea of runas in Indian knowledge system. So we have 5 runas as in debts from the community. So we actually, the whole life is repaying those loans or repaying those runas, and taking care of a mentally ill person in your family or in the community is part of that. It's nothing, you're not even doing any kind of a social service or anything. You're just repaying that debt. Again, it's a huge topic, so we will not get into that, but an idea which can be further explored. And one more thing, when we were talking about this advocacy, for professionals, I would like to also underline the fact that there are 4 areas in which a mental health professional can work. Clinical practice, of course, helping patients directly, training or teaching people. But then there are 2 areas which are less resourced or less served. One is that of advocacy, where we understand what is the Mental Health Care Act, what can we do at the level of the legal aspects or the policy aspects, pushing those things forward, because that's a full-time work and people need to invest time and money into getting that done. So people like Mona and other organizations are doing it. It's a great job. And one more thing which we are absolutely under-resourced is knowledge generation or research in mental health. We need a lot more people to document what's happening, to generate new knowledge, to understand what works for people in this particular context. And I have faced a lot of challenges being a full-time mental health researcher, but it's rewarding in its own way. And I would request mental health professionals to give some thought to also knowledge generation and mental health research aspects. Not everyone would be interested, but if some of you are interested, I would be more than happy to connect with you and share my experiences. Thank you.
Absolutely. Rahul, such a great thought. I mean, Swasti Vishwa Institute, as you know, one of our verticals is research, and we want to very much get into research because these models don't exist. There's a lot to be done in terms of research so that we can come up with certain models for our culture, our community, which work for us. So I think, there's a lot of opportunity to collaborate on this entire topic itself. Talking about Mental Health Act, I mean, in the interest of time, I think that would be a topic for another panel discussion like this for professionals, because we cannot cover the Mental Health Act in this. But know that I just would like to inform the participants here, some of them would be family members, very briefly, that there is a Mental Health Act that really protects the mentally ill. I mean, Mona was talking about family members being caring and supportive, but some families, they are also mistreating the mentally ill. They are also taking advantage of the mentally ill. They are making sure that the mentally ill are not getting the rights that they are supposed to be getting. So it is something that family members need to know, that the mentally ill are also protected by some rules and laws. So that is an entirely a different topic, but family members should be aware of these things, that, there is something called a Mental Health Care Act. And I hope I'm correct in saying this, that there are certain rights which are protected. So, Dr. Harish Shetty, if you'd just like to. You're on mute, sir.
There's again a petition against the Mental Health Act in the Bombay High Court. And so, but all these things will go on. But what is important is the Mental Health Care Act is very well thought of. But only thing, the financial part of the ill person is not ignored in this Mental Health Act, and it was taken into account in the old Mental Health Act which was there. So there are a lot of things which needs to change.
Exactly. I mean, it's not perfect in any sense, but at least people should know that there is some law, some act like this, because people are not even aware that there is something like this. So just creating this awareness and this kind of panel discussion, this is apart from our side to engage with the community, make sure that mental health is talked about in the community. People get more and more aware about these issues. And today's topic was psychoeducation, and we saw that psychoeducation is a very broad topic in its scope itself. And any final thoughts from the panelists? Maybe a minute to each one of you, in the interest of time. Any concluding remarks that you would like to talk about? Shall we start with Mona?
Thank you, Swati. I would like to take off where Rahul left, that we need to generate evidence, and need to generate evidence by keeping family members and service users and we mean people with mental health conditions, should also be involved in every research or in program that you run, Rahul. I think that's very important. For example, we talk about awareness, but a couple of years ago when I was at teens, we did this study that, we have a diagnostic system, we have information on website. When a person with mental health condition, when you read it, what do you think? Do those symptoms resonate with you? Do you identify with it? And this study was done in University of Columbia, NHS did it, and done in Delhi, in India. So we realized most people said they can't, they don't. So we need to change that. Now this study was published about 3 years ago. It was called Include Study. That was just a big thing. Similarly, let's just ask people, okay, this is a therapy. How does, these are the principles, say CBT, even let's take CBT also. These are the, we should involve whenever we do any research. I'm talking about CBT because this is what my expertise is in. That, let's see whether do we need to change it? Do we need to change the systems that we already have? Let us involve people with mental health conditions and their families as experts. Nowadays, there's this term called experts by experience. So like you're expert by training, you're a therapist, you're expert. Similarly, people are living with that condition are also experts because they know what it is like to live with it. So let us involve them, not only in advocacy, but also in research, in programs, in therapeutic interventions that we are testing. Let us involve them and, let us involve them at an equal level, not just as a lip service, not just because the funder wants us to involve. That's what's happening for many years. But now I think we should involve them actively and listen to them and whatever, treat them equal.
Correct.
And implement. Let the implementation also have, their role, whatever inputs they have, let that guide the implementation.
This is again another thought to be considered, that involve them as equals. I mean, that is so important. And I mean, now that's an entirely a different domain altogether, when you are talking about involving them, and it's so important for inclusion, especially. So that's a critical thing that we can There was one question that Indrani she had raised her hand that time, but the discussion was going on, so I could not, just interrupt that. But Indrani, if you can ask your question here, or you can type it in chat, and let's see if any one of the panel members can answer. We may just overshoot the time by about 5 minutes. So go ahead and ask your question.
Yeah, thank you so much, Swatiji. Good
Yeah,
evening,
go ahead.
everyone. First of all, I would like to thank you all for the very grateful information regarding this mental illness, and where we can, the awareness you created is really helpful for everyone. And my point is here, I'm the family member, and one of the family member is recently got schizophrenia, affected with schizophrenia. So I was taking care of her. So in that process, I faced some situations like I understood that without the help of the psychologist or psychiatrist, or without the help of lawyers, or without the help of neighbors, or without the help of practitioners, or the one NGOs or service members, social group, without help of these many people, a family member, whoever he or she is, can't handle this situation. It is very difficult. So I started collecting. I would like to share all this information, because I'm thinking that this may can help you to record this, and it can help to other those who are in needy. So I want to share this also. First I collected sorry I first I started understanding her behavior, why she is like that, why she was behaving like that. So after that I collected some information regarding that to psychologists, psychiatrists, and especially the advocacy related thing, that I don't have right to join her in hospital, as I am not her kid, or I'm not her direct blood relation. She was my brother, father's sister. So these are all the rights I have gone through, and what are all my rights, limits, and what are all I can do for her under the advocacy. First of all, I have to balance my mind levels, my thought process. These are all definitely without the help of psychologist or psychiatrist. I really am thankful to Swatiji in this, sharing my pain, and advised me on this whole process. And today my auntie is happy, and she is cured 99%. I'm happy to say this. Without help of you and all others, definitely Monaji also taken part in this. Without your help, definitely I can't handle this. Especially, of course, I'm masters in computer application, but I don't have the awareness of this mental health illness till today. That's a wonder thing. So how many are there in this country, how many are there in this world without knowing this, like me? I don't
Correct.
know, I don't know.
Indrani, sorry, I didn't know that you were the same Indrani. So, but one of the example of, people I'm working with who motivated me to conduct this panel discussion with this panel of experts is because of questions that are coming from family members like her, who are struggling to understand, who are struggling to really navigate this whole process with a family member who is suffering from mental illness. So Kita, we can take just one more question because of the
Yeah,
interest of
I will
time.
end this. I will end my question with this last question. I have a question that is, in my family members. Yes, not only in my, many families are facing the same situation. Maybe because as we are youngers or youngsters, they will not at all ready to listen. I mean, they will not at all ready to accept that what we are saying for her care. They are thinking that still we are of course in their eyes we are kids. They are not ready to accept what we are saying. They are thinking that we don't know anything. So in that case, how to deal with these elders, those who are facing illness? That's the main question. That's a very difficult thing for me. I'm not at all understanding that how to deal with this problem, because if I will say them that you are facing some issue, please come with me to, as Monaji said, they definitely will not accept. Instead, they may scold me what you are saying in front of me. How dare to say this? So we can't. I mean, we can't tell to them. We can't handle with them. So in this, but I can't leave them also because they are my family. Yes.
Exactly.
Yeah.
I think, Indrani, what your approach has been good, that, step by step, slowly. Remember what Dr. Harish said right in the beginning? That slowly only these things will change. Your elders will suddenly not change because they're from a culture, they're embedded in that culture, where you as youngsters have to listen and what they say may be right. So it is, but you have made sure that this auntie has got help, she's cured, she's doing well now, but still that those blocks are going to exist, and maybe Dr. Harish can give some more insights into this kind of a dynamic that happens where elders are not ready to accept, or they have their own way of thinking which is interfering in treatment and so on.
What works occasionally is that people whom they really regard as the Swamiji from a mutt, etc., and they say, please go to a psychiatrist, it works. Number one. Number two is some people are very cognitive, and if you give them links to read and if you give them material to read, it works. Some people always say that ek bar mein jaunga, I'll go only once because you said it. It may not be Indrani, it may be somebody else. Because of you, I'll go. And so sometimes we don't know when awakening happens in life, and we need to be constantly trying. Both is a close relative of a patient who has improved and a patient who has improved are ambassadors of great ambassadors of psychoeducation. So and कब वो दिन आएगा, कायनात कब वो window खोलेगा, with the window of opportunity, as Nina said. We really don't know. But all of us have to join hands in trying in our lifetime.
Correct. So, go ahead, keep doing that good work, Indrani, and we are all here to support you. I mean, we are all the support group, like professionals,
It's
your
tough
neighbors.
and it's long, but it's not impossible.
Yeah, exactly. Now we have one last question from Arkita. She has raised her hand, and we'll take that last question before we end the panel discussion.
Hello,
Arkita,
everyone. Yes. Is my voice audible to you all?
Yes.
Okay. So actually, just to introduce myself, that I have done my MPhil in psychiatric social work. So currently I am working as an assistant professor in Karnavati University. Thank you so much for an enlightening session. My question is, sometimes, ma'am, in families, what we have seen that one person is suffering from any particular, it can be OCD or something like that. Sometimes the mother, she is just dictating, or she, like, other family members are also following the same structure or same kind of symptoms, or following, they are also imitating the same kind of behaviors. So they all are taking it as a same behavior. Like if one is repeating the behavior, suppose it's washing or cleaning or something like that, he's giving the instruction to her child or the husband or other family members. So all starts doing the same thing. So in that case, sometimes it, like, there are certain families, so they take it as a as a mass, they all are doing the same things, and they are representing this thing as a, it's a our family system only. So at these stages, like if we are experiencing this kind of families, what strategies needs to be taken? And sometimes
difficult to say, very difficult to say with this, but
yes, sir.
Rahul will agree with me that sometimes there's this shared delusion when you live together.
Absolutely. Yes, sir.
Etc. And that is something which needs to be addressed by a psychologist, maybe separating that person or clarifying. Or
yes, sir.
I think this gentleman had earlier ways of breaking the virus of a delusional communication or behavior. I don't know. It could be anything, but I think this family should meet a team of psychiatrists and psychologists, and you should also be in that loop.
Yes, sometimes, sir, they are also not accepting. Like the belief system is so strong. Sometimes they are not ready to accept certain opinions. Yes, ma'am. Yes.
Yeah. Arkita, just a small thing here. I think we do see similar, instances in many of our things. And something that I'm just sharing with you, what I've
Yes,
done.
ma'am.
I'm not saying it's the right thing,
Yes,
but
ma'am.
usually what I do is I try to find out which among those family members
It's sick.
have, if you can say, is the reduced amount of that belief. You know,
Okay.
A has very severe, the others are following. There's one person, one son or one cousin or somebody who has got 10%. So I start building a rapport with that person,
Mm-hmm.
and I start talking to him. And then
Mm-hmm.
sometimes they are a little bit suggestive. And then I don't give them, if you ask me, no, I'm not giving them psychoeducation. I'm just putting them ideas. I just ask, do you think that you should do it? How do you feel about it? And I let him think about it.
All right.
And then I have seen that sometimes this person goes and talks to a similar level person in the family, and he says, yeah, you know what? We have been doing that for so many years now. Is it,
Yes, yes.
like today I felt like if we, whether we should do or not do, I think there enter in.
Yes, ma'am.
I'm not telling you this will work, but somewhere we have
Yes.
tried, sometimes it's work. So I think I think we have to understand one thing is, like, I'll just take over, Swati, and end it up for you. I think mental health issues, it's a wide range. Like from the one that Arkita is talking to maybe a psychiatric disorder. And
Correct.
each of them, whether it's a very small one or a major mental illness, emotional reactions are very genuine.
Absolutely, ma'am. Absolutely.
And they're very severe. They're very severe. And I think for us, I think very important is we need to understand that. And for me, I think that is what I wanted to end with. For me, psychoeducation in a clinical setup is the tip of iceberg.
Absolutely.
It's not the only thing. I think all of us, and Arkita, you especially, because we are PSWs, I think I strongly believe in this. I think
Yes,
we have to
absolutely.
go to the community.
Yes,
We
Very
have to
nice.
go to the community.
Yes,
We
yes,
have
ma'am.
to share. Sometimes my friends ask me, you're so shameless. Wherever they go, call you, you go. I said, it's okay. Even if one person listens to me and does something, I think that's
Yes.
worth it. So I think
Exactly.
go. That's the only thing. I think talk.
You need 5 Pandavas
That is
only.
psychoeducation.
You need
Exactly.
five Pandavas only. You don't need 100.
Thank
I
you.
think
Thank you
that's
so
what.
much.
Absolutely.
Thank you,
Swati,
Swati. Thank you.
I
Thanks a
want
lot,
to-
Swati.
Some
for this.
some
How
final
confident-
words from
Yeah.
Dr. Harish and Dr. Rahul.
Three things.
Yes.
All mental health professionals should be on social media, and they need to educate people, because it's a very powerful place. Don't be shy. हमको Facebook नहीं अच्छा लगता है. All that bullshit we have to cut. And number 2 is, when we treat mentally ill patients, let's look at the positive health of the family, and encouraging positive health is very important. Number 3, me and my friends here in India, we have started Hindu psychology, Indic psychology. Look at the scriptures and see whether a lot of insights are there. There is a department in MIT of Vedic psychology already in USA. So this is also a new venture which I'm learning from my friends, because for me, Beck or Das Both by Ramdas Swami is just similar. And I'm reading that in English. Unfortunately, I don't know Sanskrit. So we need to look at Indian ethos and what are the wisdom which is lying in our country, without romanticizing it, but take all the good things from everywhere.
Excellent. Final words from you, Dr. Rahul. I mean, Dr. Harish, those 3 things again, really words of wisdom. We cannot, and I think Rahul shares this mindset. We all share this mindset of community and culture and those approaches. And Dr. Rahul,
Yeah,
final
well,
words.
just thank you so much, Swati, to you and Dr. Shetty, Dr. Shekhar, Mona, everyone else, and for this very lively discussion. Just 2 things. One is that we, as mental health professionals, psychiatrists, psychologists, psychiatric social workers, everyone included, we should we should leave this hats of being experts, because there is so much to learn and expertise comes in the way of learning. My patients teach me a lot, my community members teach me a lot, everyone teaches me a lot. So there is a lot to learn from all these interactions. Once we shun this, I mean, we must have read a few things and we can share a few things with people, um, uh, because that's what we have done till now, and leave it at that and try to keep learning more and more from people around you, because that can be helpful. This is not just for mental professionals, but even for family members, because they can be learners as well. I mean, having a mental health patient in family could be a learning experience in itself. And I'm not saying this just for the sake of saying it. I had my own fair share of sufferings, so and I'm thankful to them for having those kind of sufferings. And second thing is about what Dr. Shetty mentioned about what we call as Indian psychology now, bringing from Indian knowledge systems, and there's a whole lot of stuff which could be done. Maybe Swati, you should think of arranging a whole new set of a panel discussion on how Indian knowledge system can contribute to global mental health or global psychology, and it is not just for the Indians. It is of the benefit for the entire humankind. So
Yes, absolutely. Absolutely. So I think Rahul, again, lot of things for all of us to think about, a lot of perspectives here. When we started the panel discussion, it was psychoeducation and very specifics of it, almost the mechanics of it. But the panel discussion has ended up in a much more systems view, I should say, the dynamics of it, how it moves through different viewpoints, I should say. It's not so psychoeducation has all these aspects, and it's a good thing that we have recorded it so that we can go back and listen to it again, because there are a lot of perspectives which have come out through this panel discussion here today. Lot of learnings for all of us. We are professionals, but end of the day we are also family members, and it is giving us perspectives even in our own lives. So with that, thank you so much, Dr. Shetty, Dr. Amila, Mona, and Dr. Rahul. It has been amazing to interact with you. I want to thank Aditi and Meghna for their help, helping me in putting this together. And thanks to our panelists once again. Thanks to all the participants who are here. And I'm sure there are folks who are watching on YouTube, and it's going to go on YouTube afterwards, so people will watch it there. So thank you for so much of showing interest in this topic, coming together to attend this, and together we can make a change. All the attendees here, whether they are family members, whether they are people who are suffering from mental illness, whether they are professionals like us, or whether they are general public who's interested, each one of us has a role to play in this, and together we can make a difference here in whatever way we can, little or big, or it doesn't matter, but whatever we can, we should do for advocating mental health, making sure that we are talking about it, making sure that it becomes acceptable and not stigmatized, and making sure that we take charge of our own treatment and our own well-being. I mean, end of the day, it should all result in psychological well-being, which is healthy living. So with that, I will close this panel discussion. Thank you so much. And two more topics for new panel discussions have come. And if we are going to get experts like this, I'm motivated. Thank you so much.
Thank you, Swati. Thank you for this opportunity for coming together. I think that's beautiful.
Yeah, agree. Thank you.
Thank you. Bye-bye.
And Swati and Rahul, thank you.
Thanks. Okay, we can end this thing. Meghna, you can end the session. Thanks.
Yes, ma'am.